considering the extreme complexity of the risk and protective factors that we now understand through Alzheimer's research, what are some of the major hurdles in figuring out how they interact with each other? And how can that knowledge lead to more personalized and effective prevention strategies, treatments, and how is that articulated through the research?
I
George, you
can
want
tell.
to go first?
Yeah.
What one of the great hurdles right now is that we do not have all of the biomarkers that we need. We have reasonable biomarkers for amyloid, different forms of amyloid. We have biomarkers for tau and different forms of tau. But TDP-43 is frequently present in the brain, and we have no biomarker of that. Synuclein is frequently present in the Alzheimer brain. We have no biomarker of that. There's a CSF seed amplification assay that looks pretty good, but it's not really practical or widely used yet. We don't have very good plasma biomarkers of inflammation, and that's one of the primary processes of Alzheimer's disease. So I think in terms of the hurdles, it is the ability to see the co-pathologies that we know are there because we can see them at autopsy. We want to prevent them. We want to understand whether they are limiting the treatment benefit we can see with anti-amyloid therapies. We want to see whether we can do combination treatments with a TDP-43 drug and a monoclonal antibody, for example. These are the questions that must be answered, but we can't do it until we have a biomarker. So I see the identification of those biomarkers as a major challenge and a major goal for the field right now.
Outstanding. And Suzanne?
Yeah, from a statistical standpoint, I think a lot about interactions with medical history or comorbidities. And even when we don't have biomarkers to measure them, we kind of have some indication of the types of people who may have them, at least in our trials, based on some of those medical history reports, medications that they're on, things like that. It's been really interesting because there are publications that show that those comorbidities are good predictors of the patients who will both benefit the most and who will have the biggest safety risk in many cases. And there are publications that show that people who have, for instance, higher blood pressure are more likely to have ARIA risk with the monoclonal antibodies. But in a lot of cases, those comorbidities are the things that can be improved the most with treatment. And the reason is that everything gets worse when you have Alzheimer's symptoms. You forget to take your medication, you're not managing all of your other comorbidities as well. All these kinds of things are what really end up costing a lot of money and reducing the quality of life for the patients with these comorbidities. And so we see really substantial benefit with monoclonal antibodies, partly because these comorbidities are reduced. And so it's really a complicated interaction where you need to factor it in on the safety side and also on the efficacy side. And if we can be more explicit about it because we, get access to biomarkers that can give us better insights, then we can do it more proactively and do it in a way where those safety risks are minimized, but we still get the additional benefit that we might obtain in the patients who really need it and who hopefully won't be excluded from the clinical trials, because in some ways the clinical trial populations focus on a cleaner group. And once you go out to the community, there's a lot more comorbidities, and that's where the real big benefit will happen. So it might be that the benefit in the community could actually be a lot bigger than we see in clinical trials because of that broader group who can really have that benefit across all the comorbidities as well as for just the main core Alzheimer's disease symptoms.
And speaking of clinical trials, do you see a space where we're going to start to see the ages of enrollment in clinical trials start to reduce, thinking through that, risk perspective and the concept that change is already happening in the brain, 20 years often before symptoms are developing? Do you think we're going to start to see clinical trials that are going to be looking at individuals earlier and following them or in a longitudinal pathway, especially folks who have like the ApoE4 lipoprotein?
Let me jump in on this one first, if you don't mind, Jeff. This is one where I think it's sort of this trade-off, and we've talked about this a lot in the Alzheimer's space in terms of study design, that you can either study the disease when it's measurable or when it's changeable. Can you intervene early enough to make a difference and late enough that you can measure that difference? And for proof of concept studies that are really small sample sizes, it's very hard to do both. If you're a big company and you're in phase 3, you can just put more patients into the study and you can measure really slow, subtle, early change. But if you're a small company and you're trying to get proof of concept, you need to measure patients that have enough decline. And sometimes when you go to those earlier, younger patient populations, the decline isn't quite as steep and you're not able to see the treatment effects that you need to. And so there will always be a little bit of a disconnect between the population you need to study in a proof of concept small trial, and then the group you would study in a phase 3 that might be kind of intermediate, and then the group that will eventually be treated out in the community. And it's important to make those decisions carefully, because otherwise you could miss proof of concept when you truly have a treatment that works. So you don't want to try to go too broad too soon, or you might miss your chance for success.
Understood. Jeff, do you have anything to add to that?
I would just add that an important part of this dialogue is about biomarkers and their regulatory status,
Yeah.
so that a trial could have a positive outcome of a delay in biomarker maturation if the regulatory agency had enough confidence that that biomarker would eventually predict clinical benefit. And we're in the process now of accruing this kind of information which would allow us to have that kind of confidence. So I think there are a lot of moving pieces here, but two of them are the regulatory part of this and the biomarker part of it.
Yeah,
Understood.
one thing I want to add to that, the biomarker part is interesting, because at first you can have a biomarker that could be an accelerated approval biomarker where you get full approval, but it's accelerated approval. You still need to confirm it with a clinical trial based on, so you do the study based on the biomarker, you confirm it with a clinical trial that then shows a clinical benefit. But the second option is really the direction that we should be trying to go, and we obviously are trying to go, which is where you have a biomarker that's established well enough as a surrogate that you get full approval without any kind of conditions. And it's not accelerated approval, but it's actually full approval based on a fully established surrogate. And so getting our biomarkers to the point of surrogacy is really critical, because if we can get full approval using biomarkers, that allows us to be studying patients early. It allows us to be in the stage where we're making the biggest difference and see the biggest benefit. And so that is the direction that we want to be going. And maybe an intermediate step is having a biomarker that could be accelerated approval outcome, and then moving it to where it could be a standalone surrogate and be able to be full approval, have full approval based on that outcome.